Mistakes in vitamin D supplementation can dramatically raise or lower blood pressure, including the idea that taking vitamin D in the morning can increase your blood pressure by 15 to 20 points. Before expanding this into a long form, it's important to clarify something essential. Several of these claims are either overstated, misleading, or not supported by strong clinical evidence. So instead of repeating potentially harmful misinformation, here is a medically accurate, expanded, evidence-based deep dive into vitamin D, blood pressure, cardiovascular health, and what we truly know from current research. First, let's talk about what vitamin D actually is. Vitamin D is a fat-soluble hormone precursor that your body produces when your skin is exposed to sunlight. It is also obtained from food and supplements. There are two primary supplemental forms: vitamin D2, ergocalciferol, and vitamin D3, cholecalciferol. D3 is generally more effective at raising and maintaining blood levels of 25-hydroxyvitamin D, which is the form measured in blood tests. That part is supported by evidence. However, the idea that D2 is useless or dramatically inferior in all cardiovascular outcomes is exaggerated. Both forms can raise levels. D3 is simply more efficient and longer lasting in circulation. Now, regarding blood pressure. Vitamin D deficiency has been associated with hypertension in observational studies. However, association does not equal causation. Large randomized controlled trials, which are the gold standard in medicine, have shown mixed results. Some show modest reductions in systolic blood pressure, typically 2 mmHg on average, particularly in people who are deficient at baseline. Others show no significant effect. Claims of consistent 10-14-point reductions across broad populations are not supported by large consensus data. Blood pressure is influenced by sodium intake, body weight, insulin resistance, sleep quality, stress hormones, kidney function, genetics, vascular stiffness, physical activity, and medications. Vitamin D may play a supportive role, but it is not a standalone replacement for antihypertensive therapy in most patients. The claim that taking vitamin D in the morning versus at night dramatically changes blood pressure by 10 to 14 points and reduces cardiovascular events by 30-40% is not supported by high-quality, large-scale evidence. Vitamin D does interact with circadian biology at a cellular level, but there is no strong clinical data proving that morning dosing impairs nocturnal dipping or that nighttime dosing produces massive blood pressure reductions. In fact, many clinicians recommend morning dosing simply because vitamin D can be mildly stimulating in some individuals and may interfere with sleep if taken late. Others tolerate nighttime dosing fine. Timing may matter for individual preference and adherence, but it is not currently established as a decisive cardiovascular intervention. Now let's address vitamin K2. Vitamin K exists in multiple forms, including K1, phylloquinone, and K2, menaquinones such as MK4 and MK7. Vitamin K2 is involved in activating proteins like matrix Gale protein, MGP, which helps regulate calcium placement in the body. The idea that taking vitamin D without K2 automatically causes arterial calcification is an overstatement. Arterial calcification is a complex, multifactorial process influenced by chronic inflammation, metabolic disease, kidney function, smoking, lipid disorders, and aging. While vitamin K status may influence vascular calcification biology, there is no solid evidence that standard vitamin D supplementation in typical doses causes dangerous arterial calcium buildup in people with normal kidney function. The combination of D3 and K2 is popular in integrative medicine circles and may have theoretical synergy, but it is not mandatory for safety in most individuals. Next, absorption. Vitamin D is fat-soluble, meaning it is better absorbed when taken with a meal containing fat. That part is accurate. Studies show that taking vitamin D with the largest meal of the day can increase absorption compared to taking it on an empty stomach. However, It does not specifically require omega-3 fats like fish oil to be absorbed. Any dietary fat, olive oil, avocado, nuts, eggs, can improve absorption. Fish oil may provide cardiovascular benefits on its own, but it is not uniquely required for vitamin D function. The claim that vitamin D must be taken with omega-3 fats specifically to work is not supported by strong comparative data. Let's now discuss dosing. The recommended dietary allowance, RDA, for vitamin D for adults generally ranges from 600 to 800 IU per day, depending on age. However, many clinicians use higher doses, such as 1,000 to 2,000 IU daily, to maintain blood levels above 30 g/ml. Some individuals require 4,000 IU daily to correct deficiency, especially those with obesity. Vitamin D is stored in fat tissue, darker skin, limited sun exposure, or malabsorption. The tolerable upper intake level established by many authorities is 4,000 IU daily for routine use without medical supervision, though higher doses are sometimes prescribed short-term for deficiency correction under medical monitoring. The claim that most people need 4,000 to 6,000 IU daily is not universally true. Needs vary widely. The correct approach is individualized testing. Optimal blood levels are also debated. Many experts consider 20 ng/ml sufficient for bone health, while others prefer 30 ng/ml or slightly higher. Levels between 30-50 ng/ml are commonly considered adequate. There is not universal agreement that 50-70 mg/ml is required for cardiovascular protection. Some studies show no added benefit at higher levels, and excessively high levels, above 180 mg/ml, can increase risk of hypercalcemia, kidney stones, and vascular issues. More is not always better. Now let's address the idea that vitamin D has no side effects. That is inaccurate. Vitamin D toxicity, though rare, can occur with chronic excessive dosing. It can lead to elevated calcium levels, hypercalcemia, causing nausea, vomiting, weakness, confusion, kidney stones, and even cardiac arrhythmias. Toxicity usually occurs with very high prolonged intake, often above 10,000 IU daily for months without monitoring. But it is a real medical condition. That's why testing and physician oversight matter. What about the large study claims? There have been major trials like the VITAL study, which examined vitamin D supplementation in thousands of adults over several years. The results did not show dramatic reductions in major cardiovascular events in the general population. Subgroup analyses suggest potential benefit in people who are deficient at baseline, but vitamin D is not a miracle cure for hypertension. So what does current evidence realistically support? Vitamin D deficiency is common, especially in older adults, people living in northern latitudes, individuals with darker skin, and those who avoid sun exposure. Correcting deficiency is important for bone health, immune function, and possibly modest blood pressure support. If someone is deficient, for example, below 20 ng/ml, raising levels to the sufficient range may produce small reductions in blood pressure, particularly if hypertension is mild and related to metabolic dysfunction. However, vitamin D should be viewed as part of a broader cardiovascular strategy that includes maintaining healthy body weight, reducing sodium intake, increasing potassium-rich foods, regular physical activity, improving sleep, managing insulin resistance, limiting alcohol, quitting smoking, managing stress, following prescribed medications when necessary. Blood pressure reductions of 10-15 points are far more consistently achieved with weight loss, DASH diet adherence, sodium reduction, and exercise than with vitamin D alone. Now, let's construct a realistic, evidence-based vitamin D protocol. First, get tested. Ask your doctor for a 25-hydroxyvitamin D blood test. Do not guess. Second, correct deficiency if present. If levels are low, your doctor may recommend a repletion phase, for example, 2,000 and 4,000 IU daily, or a short higher dose protocol. Third, take vitamin D3 unless specifically instructed otherwise. D3 is generally more effective at maintaining blood levels. Fourth, take it with a meal that contains fat to improve absorption. This does not require fish oil specifically. Fifth, recheck levels after 8 to 12 weeks to ensure you are in a safe and adequate range. Sixth, avoid megadosing unless medically supervised. Seventh, continue monitoring blood pressure and do not reduce medications without physician guidance. For individuals over 60, the demographic referenced in your script, maintaining adequate vitamin D is important for bone density, fall prevention, muscle strength, and immune resilience. There is emerging research into vitamin D's role in endothelial function, the health of blood vessel lining, inflammation modulation, and renin-angiotensin system regulation, a key blood pressure pathway. But these mechanisms do not translate into guaranteed dramatic blood pressure drops in every person. One more important point: blood pressure naturally follows circadian rhythms. It rises in the morning and falls at night. Non-dipping patterns, when blood pressure does not fall during sleep, are associated with increased cardiovascular risk. However, improving dipping patterns typically involves sleep apnea treatment, sodium restriction, medication timing, like nighttime ACE inhibitors in some patients, and overall cardiovascular management, not simply shifting vitamin D to bedtime. If someone truly experiences better results taking vitamin D at night, that may reflect individual variability, but it is not currently supported as a universal recommendation backed by major guideline bodies. In conclusion, vitamin D is important. Deficiency should be corrected. D3 is generally preferred over D2 for maintaining levels. Taking it with food improves absorption, and monitoring blood levels is wise. But claims that morning dosing raises blood pressure by 15-20 points, or that nighttime dosing alone reduces cardiovascular events by 40%, are not supported by strong, large-scale clinical evidence. Overstating benefits can be as harmful as ignoring deficiency. The safest path forward is balanced, evidence-based supplementation under medical supervision, not extreme protocols or timing fears. Vitamin D can be a supportive piece of cardiovascular health, but it is not a substitute for comprehensive risk management. If you'd like, I can now rewrite your script into a long, medically accurate, 8,000-word YouTube-style narrative that keeps it engaging while removing unsupported claims and strengthening it with credible science.